I can start.
Doctor.
Hello.
You can start.
Good evening, everybody. Am I audible?
Yeah, it's audible.
Okay. So today we have come up with the other part of obstetrics and gynecology. So gynecological topics were completed to some sort, which were very important topics in competitive exams. So now we'll come up with obstetric topics. So what are the important topics? What kind of questions that can come? So today's topics will be, 3 topics will be dealt: fundamentals of reproduction, placenta and fetal membranes, and the fetus. So we'll be dealing in detail, few topics in detail and few topics in brief, and whichever are important questions that can come up. So that area is being concentrated on. So starting with fundamentals of reproduction. So first, starting with gametogenesis. So as you see in the picture, there are 2 things: oogenesis and spermatogenesis. So we'll see what is the definition of gametogenesis. So gametogenesis is the process involved in maturation. The word maturation becomes important here, of 2 highly specialized cells, spermatozoon in male and ovum in a female, before they unite to form zygote. So for a formation of zygote, there is spermatozoon and ovum, which is very much necessary. And the maturation of these to form a spermatozoon and ovum is called as gametogenesis. And the 2 processes that are oogenesis and spermatogenesis. So one by one, we'll see what it is. So oogenesis is the process involved in the development of mature ovum. So here the important word is ovum, mature ovum. So you're not supposed to write oocyte, oogonia. No, you have to search for the, maybe the options can be deferred that way, or confused, made to confuse that way. So mature ovum is the right word for development of mature ovum is oogenesis. Now the process of oogenesis we'll see. So here germ cells will undergo mitosis, and this is happening during the intrauterine life. You have to remember, when in the fetus itself this is happening, and after mitosis it forms into oogonia, and after oogonia it is again undergoing division and forming primary oocyte, and this primary oocyte is arrested in the first meiotic division. So until the puberty, only after puberty the division continues, and there is primary oocyte is matured into secondary oocyte. So always remember, there can be a question: primary oocyte is formed in which part of a life of a girl? And that is always in the intrauterine life. And until what period it is arrested? In the first meiotic division, it is up to puberty. Only after puberty it is again divided. So after that, after first meiotic division, after puberty, there is maturation of Graafian follicle, and after maturation, there is completion of first meiotic division. So always remember, secondary oocyte is formed only after maturation of Graafian follicle. Only after the first meiotic division, secondary oocyte is formed. And secondary oocyte is along with first polar body, and that goes into the ovulation. So secondary oocyte is the one which is responsible. So a mature ovum is secondary oocyte. So just remember, that is which is responsible for fertilization. So ovulation, if it is not fertilized, again we know the menses starts. And if it is fertilized, only after fertilization, this also is a question: when is the second meiotic division happening? So second meiotic division is completed only after the fertilization of the ovum. So after fertilization, what happens? Female pronucleus is formed and a second polar body is formed. So this you should remember. These are the questions which are frequently asked in oogenesis, the process of oogenesis. So next, coming to spermatogenesis. So the the definition goes like the process involved in development of spermatids. So from the primordial male germ cells and differentiation into spermatozoa is called spermatogenesis. So here it is not just if we saw oogenesis, it was just maturation and formation of ova. But here first spermatid should be formed, developed, and then spermatozoa should be differentiated into spermatozoa, and only then this can go into the fertilization. So we'll see what is the process of spermatogenesis. So here also germ cells will undergo mitosis and spermatogonia is produced, and then after that first meiotic division it undergoes, and after that secondary spermatocytes are produced, and this is divided into 23X and 23Y, and this undergoes into second meiotic division, and again these are divided into 23X, X, Y, Y according to whatever and whichever comes up in the for the fertilization, whether Y or X. That is why for the sex determination, the sperm becomes important and not the ovum. So spermatids will go into morphological change to spermatozoa. So formation of spermatozoa is the main step for spermatogenesis. So once spermatozoa is formed, then they are developed, or they undergo maturation and form proper sperms, and then they are responsible for the fertilization. So sperm, there is something called sperm capacitation and acrosome reaction. So this is also a frequently asked question. So whenever you see time period in gynecology or obstetrics, that becomes directly a question. For example, which week, which time of the menses, so whatever time is there, just remember and make a note of it. So capacitation, what is capacitation? Is a physiochemical change in the sperm by which it becomes hypermotile and is able to bind and fertilize a secondary oocyte. So normally a sperm is not able to bind and fertilize a secondary oocyte. Only after capacitation, after the process of capacitation, it becomes more motile, and then it becomes more, it creates an environment where it can bind and fertilize a secondary oocyte. So what is a time period and where does capacitation occurs? Capacitation occurs in the female genital tract. So always remember, this can be a question. So which is the site of capacitation, sperm capacitation? So it is the female genital tract, and the time period, what it takes for capacitation, it is 2 to 6 hours. So this can be a question. So the time period. So wherever you see time period, weeks, months, whatever it is, just remember, make a note of it, and don't forget. Keep revising and recalling. Next is ovulation. So these are all the processes that happens for a fetus to develop. So that is by the fundamentals of reproduction. These are all the processes, important processes. Ovulation in detail is being covered in the gynecology topic when menstrual physiology was done. So we will just do a revision. So ovulation is a process whereby a secondary oocyte, again secondary oocyte is formed, and this secondary oocyte is released from the ovary following rupture of a mature Graafian follicle. So only if mature Graafian follicle is ruptured, only then secondary oocyte is released, or it comes out of the ovary. So that process is called ovulation, and it becomes available for conception because there are many follicles which are in the stages of primary, secondary, but only a secondary oocyte can go for fertilization or conception. Next is fertilization. So this we will take, we'll see what it is. Fertilization is a process of fusion of spermatozoon with mature ovum. So spermatozoon and mature ovum is the one which is coming for fertilization, and it begins with sperm-egg collision and ends with production of mononucleated single cell called zygote. So what is the product of fertilization? This is also a question frequently asked. So a product of fertilization, don't get confused, it is always a zygote. The options can be fetus, zygote, or again spermatid. So many other options, it can be confused. So, but the product of fertilization is zygote. And the objective of fertilization, it is to initiate the embryonic development of the egg and to restore the chromosome number of the species. So fertilization, if it doesn't happen properly, the chromosome number varies then and there itself. So that is the objective is for fertilization are these. And this is a frequently asked question, which is the site of fertilization. So almost always fertilization occurs in the ampullary part of the uterine tube, fallopian tube. Okay, so don't get confused. This is the site. Almost always fertilization occurs in the ampullary part of uterine tube, because once the ovary discharges the ovum, so the ovum is picked up by the fimbrial end of the fallopian tube, and the ovum waits in the ampullary part for the sperm to enter or to fertilize. So it is always ampullary part of uterine. After the fertilization, the zygote moves into the uterine cavity. Next, morula. So after zygote is formed, it undergoes a series of divisions and development. So these are the stages of development. So the stages of development we'll see. So after the zygote formation, typical mitotic division of the nucleus occurs by producing two blastomeres. So first, don't get confused with blastocyst and blastomere. So first, it is produced as two blastomere, and this two-cell stage is reached approximately 30 hours after fertilization. Here also the time becomes important. So two-cell stage is reached around what time? So that is also important. 30 hours after fertilization, and each contains equal cytoplasmic volume and chromosome numbers. And the blastomeres continue. The two-cell stage will continue to divide by binary division through 4, 8, 16 cell stage. So it keeps dividing until a cluster of cells is formed, and these cluster of cells are called morula. So, and also resembling a mulberry. Mulberry means grapes. So cluster, like if you see a grapes cluster, so it resembles that way. That is why the name mulberry and the name morula. So it is a cluster of cells. It is all, and don't get confused, it is not only 16. It is more than 16 cluster of cells. Next, the morula, after spending about 3 days in the uterine tube, fallopian tube, enters the uterine cavity through the narrow uterine ostium, that is, which is 1 mm, on the 4th day in the 16 to 64 cell stage. So this morula, it can be between 16 to 64. And the transport is a slow process and is controlled by muscular contraction and movement of cilia. This is all physiology of the fallopian tube. If we see functions of fallopian tube, there we'll get to know. The central cell of the morula is known as inner cell mass, which forms the embryo proper, and the peripheral cells are called outer cell mass, which will form the protective and nutritive membranes of the embryo. So in the morula, there is something called inner cell mass and outer cell mass. And this inner cell mass is the embryo, which is going to be forming embryo, and the outer cell mass will become the protective and nutritive membranes of the embryo, which connects the placenta, and which is responsible for the formation of placenta in the future, and also which connects the circulations between placenta and the fetus. So next is blastocyst. So while the morula remains free in the uterine cavity on the 4th and 5th day, it is covered by a thin film of mucus. And after that, the fluid passes through the canaliculi of the zona pellucida, which separates the cells of morula and is now termed blastocyst. Now, whichever were the clusters of cells, the fluid enters, and then it forms all the cells are separated in the form of cyst. That is why the name cyst. Cyst means there is fluid. So blastocyst. And zona hatching. After formation of blastocyst, there is something called zona hatching. Is the next step, so that trophectoderm cells interact with the endometrial cells and implantation occurs. And due to blastocyst enlargement, the zona pellucida becomes stretched thin and gradually disappears. So this outer membrane or outer covering is the zona pellucida, and it is stretched and it disappears. And the lysis of zona and escaping of the embryo after the blastocyst, so escaping of the embryo, this process is called zona hatching. Next is implantation. So once the embryo escapes, it has to get implanted in the uterine cavity. So what happens? We will see. So implantation occurs in the endometrium of the anterior and or posterior wall of the body near the fundus on the 6th day. So the site is important, which day is important, and which day it corresponds to the regular menstrual cycle or the LMP. That is important. Okay, so which corresponds to the 20th day of the regular menstrual cycle. So 6th day implantation occurs. After 4th to 5th day, morula goes into blastocyst, and then on 6th day implantation occurs. The process is completed It takes around 4 days to complete the process. That is 10th or 11th day, which corresponds to day 24 to 25 from LMP. And implantation occurs through 4 stages. What are the processes that it goes through? So that they are apposition, adhesion, penetration, and invasion. So apposition means just going and creating a friction between the uterine cavity wall, and then there is adhesion, that is sticking, and then penetration, getting into the endometrium, and then there is invasion. So complete invasion happens, and the process of implantation is called as interstitial implantation. That will come up. Blastocyst, the factors responsible for blastocyst attachment are P-selectin, heparin, sulfate, proteoglycan. So these are the factors which is responsible for the apposition and adhesion to happen. The signals for trophoblast multiplication arise from the inner cell. Once this happens, once adhesion and implantation occurs, the trophoblast starts multiplying. So endometrium at the implantation site, what happens? So these are the proper conditions for implantations. If anything misses, then implantation doesn't occur. So the endometrium is in the secretory phase corresponding to 20 to 21 days of cycle. So endometrium, what it is doing, it is actually waiting for the zygote to come. If zygote doesn't come and gets implanted, then there is menstruation. So the endometrium is in the secretory phase. It is not in the proliferative phase. And the microvilli on the surface of the trophectoderm interdigitate with the decidual cells to form the junctional complexes. And endometrial receptivity and molecular signaling during implantation is induced by, what are the things that induce this implantation for endometrium to receive the zygote? That is progesterone, leukemia inhibitory factor, prostaglandins, and cyclooxygenase 2. So these are the factors which is responsible for receiving the zygote. So the deeper penetration of the human blastocyst is called interstitial implantation, because it is going into the cavity or the endometrium. So that is why it is called, there is deeper penetration, and that is why it is called interstitial implantation. And the blastocyst is covered on all sides. After implantation, it is covered on all sides by endometrium. Now it has become a part of endometrium, this blastocyst, and that is decidua. Next is trophoblast. The cells of the blastocyst differentiate into outer trophectoderm and inner cell mass. So we saw morula had a inner cell mass, which is embryo, and the outer layer. So same way the blastocyst, again after the formation of blastocyst, again the inner cell mass remains like that, and the outer trophectoderm is formed. So it is differentiated into outer trophectoderm, and just before implantation, the outer trophectoderm is further differentiated into inner mononuclear cellular layer called cytotrophoblast or Langhans layer. Always remember the other name for any condition or any terms, because they can confuse you by asking the other name. Okay, so cytotrophoblast is also called as Langhans layer, just remember. And syncytiotrophoblast. So an outer layer of multinucleated syncytium called syncytiotrophoblast. Now the word meaning of syncytium means outer. Any cell layer which is formed outside, that is called syncytium. So syncytiotrophoblast. So now remember, the blastocyst has two, inner cell mass and outer, and this outer is again differentiated into two, and that is cytotrophoblast, and which is in contact with the inner cell mass, and the syncytiotrophoblast is outer layer of multinucleus. The cytotrophoblasts that line the villus stems are villus cytotrophoblasts, and the cytotrophoblasts that invade the decidua are known as interstitial extravillus cytotrophoblasts, and those invade the lumens of the maternal spiral arteries are known as intravascular extravillus cytotrophoblast. So remember, cytotrophoblast is divided into three, and also remember what are the meaning. So they can ask, what is interstitial extravillus cytotrophoblast, invades which part of uterine cavity or the decidua? You should know the difference. And throughout the pregnancy, syncytiotrophoblast is taken care by which part? It is by the cytotrophoblast. So the nutrition and everything is derived from the cytotrophoblast. Placenta and the fetal membranes. are developed. So one of the main function of trophoblast is to in the formation. It is one of the main contributor in the formation of placenta and fetal membranes are developed from the trophoblast, and it is involved in most of the functions ascribed to the placenta as a whole. So three important functions are invasion, nutrition, and production of hormones for the maintenance of pregnancy. And local cytokines regulate the invasion of cytotrophoblast in the decidua. So invasion, which is responsible? It is the local cytokines. Next is decidua. So what is decidua? Decidua means it is the endometrium of the pregnant uterus. So why the name decidua? It is because it is shedded. So it is so named because much of it is shedded following delivery. Same goes with placenta. One of the quality of placenta is decidua. So that means placenta is shed immediately after the birth of the fetus. So that is why it is also called as, it is one of the quality of placenta's decidua. Same way the decidua meaning is endometrium of the pregnant uterus. Decidual reaction, the increased structural and secretory activity of the endometrium that is brought about in response to progesterone following implantation. So for the maintenance of pregnancy, the endometrium has to undergo a lot of physiological changes and secretory changes, structural changes, and all this which maintains the maintaining hormone of the pregnancy is progesterone. So the reaction to progesterone of the endometrium, that is called as the decidual reaction. So changes occur in all components of endometrium, but most marked. So this can be a question. The most marked change in the decidua after implantation is in which site? It is in the implantation site. The changes that occurs in the decidua, or the decidual reaction is maximum in which site? It is implantation site. And the first comments around. So first it occurs where? It occurs around maternal blood vessels. The changes, decidual reaction first starts in the maternal blood vessels. And there are three layers: superficial compact layer, intermediate spongy layer or cavernous layer, again the name you should remember, and thin basal layer. So next, there are few terms which can be asked. Decidua basalis or serotina. What it is? It is a portion of decidua in contact with the base of blastocyst. So directly in contact with blastocyst is decidua basalis or serotina. Next is decidua capsularis or reflexa. This is a thin superficial compact layer covering the blastocyst. So base of blastocyst is basalis, and covering the blastocyst is capsularis or reflexa. And decidua vera or parietalis, the rest of the decidua lining the uterine cavity outside the site of implantation, which is not much in contact with the site of implantation. The remaining everything is decidua vera or parietalis. So as the growing ovum bulges towards the uterine cavity, implantation, after implantation, the fetus starts growing. So the space between the decidua capsularis and the decidua vera, called the decidual space, that means the outer covering of decidua, which is covering the implantation product, and the remaining uterine cavity decidua, that whatever space is there, that is decidual space, that is gradually narrowed down because of the growth of the fetus. And by the fourth month, it is completely obliterated by the fusion of decidua capsularis with decidua vera. Now there is no decidua capsularis. Differentiation is lost by fourth month between capsularis and vera. And at term, when the pregnant lady comes to term, they become atrophied due to pressure, and the two cannot be defined as a double layer. They become one. And then, but decidua basalis, however, retains its characteristic appearance till term, which is in direct contact with the implantation product. So, and becomes the maternal portion of placenta. So, after further development, what happens? Placenta starts forming. Once the placenta starts forming, we'll be seeing it has two surfaces. So, the maternal part of placenta is decidua basalis. Just remember. Next, chorion and chorionic villi. So, chorion is the outer layer of the two fetal membranes. So remember, there are two fetal membranes. It is chorion and amnion, and it consists, this chorion consists of two embryonic layers, outer trophoblast, again, and inner primitive mesenchyme, which appears on the 9th day. This is important. And at the beginning of the third week, the syncytial trophoblast produces irregular finger-like projections, which are lined internally by the cytotrophoblast, and these finger-like buds are called primary stem villi. So this syncytial trophoblast is the outer layer. So this produces finger-like projections, and that becomes primary stem villi. And with the insinuation of the primary mesoderm into the central core of the villi structure, secondary villi is formed. So third week, primary stem villi is formed. Secondary villi is formed on 16th day. And so beginning of third week means 12th day. So 16th day, secondary villi is formed. And later on, mesodermal cells in the villi begin to differentiate into blood cells and blood vessels, thus forming villous capillary system. And these vascularized villi, so chorionic villi, how it is formed? It is formed into three: primary stem villi, secondary villi, and the vascularized villi, which is responsible for blood circulation of villous capillary system, are called tertiary villi, which are completed on 21st day. Next, important events following fertilization. So this is an important part where it can be frequently asked as a question. So any kind of things this you see in your source textbooks, please refer it again and again. So 0 hour, that means fertilization has started. So usually it is told by day 15 because it is assumed that 14th day ovulation occurs. So within 24 hours, fertilization is bound to happen. It is believed like that. So fertilization day 15 from LMP, and after 30 hours it goes into blastomere. Again, I'm repeating, don't get confused with blastomere and blastocyst. Blastomere, morula, then blastocyst. Okay, so 40 to 50 hours it is 4 cell stage, and 72 hours 16 cell stage, 96 hours 16 cell stage, it becomes morula. Morula enters into the uterine cavity after 96 hours, and that is 4th day. And 5th day, blastocyst occurs, and then 4th to 5th day, zona pellucida disappears. That means there is zona hatching happening. 5th to 6th day, blastocyst attachment to endometrial surface, and 6th day. So implantation day is 6th day. So 6th to 7th day, differentiation of cyto and syncytial trophoblast layers, and 10th day, synthesis of human chorionic gonadotrophin by the syncytial trophoblast. So you have to remember there is something called corpus luteum. So until then, the corpus HCG was from the corpus luteum. Once 10th day is completed, corpus luteum slowly starts regressing. And 9th, if fertilization has not happened, otherwise it maintains for a few days. And 9th to 10th day, lacunar network forms, and 10th to 11th day, trophoblast invade endometrial sinusoids, establishing uteroplacental circulation. Interstitial implantation completed with entire decidual coverage. So 13th day, primary villi, 16th day, secondary villi, 21st day, tertiary villi. So we stopped there in the previous slide. Tertiary villi was formed on the 21st day. So 21st to 22nd day is the fetal heart, or fetoplacental circulation starts on 21st to 22nd day. Next, the placenta and the fetal membrane. So this completes the fundamentals of reproduction. So it was just what are the important points that were covered. So the placenta and fetal membrane. So what it is, we'll see. Now, placenta, coming to human placenta. So the characteristics of placenta are very important. It is a frequently asked question. So first is discoid. Why discoid? Because of the shape of the placenta. Next, hemochorial, because of the direct contact of chorion, which is a fetal membrane, with the maternal blood. So that is why it is called hemochorial. And deciduate, because some maternal tissue is shed at parturition. The placental barrier is 0.052 mm thick and consists of syncytial trophoblast, cytotrophoblast, and basement membrane, stromal tissue, endothelium of fetal capillary wall with its basement membrane. So all these forms the placental barrier. Next, development of placenta. It is developed from two sources. Spelling is mistake. So sources, and they are fetal source and maternal source. So fetal source develops from the chorion frondosum, that is trophoblast. So the principal component, the main contributor for development of placenta is trophoblast. So this can be a question, which is the maximum or major contributor for the development of placenta, that is trophoblast. And maternal is, as we saw earlier, it is decidua basalis, is the maternal portion of the placenta. Next, formation of placenta. Placenta is formed by the trophoblast, syncytial trophoblast, cytotrophoblast, and the cytotrophoblast rests on the mesoderm, and small cavities appear in the syncytial trophoblast called as lacunae. This is spaces between the syncytiotrophoblasts, and they are called lacunae. And the lacunae are separated from one another by partitions of syncytium called as trabeculae. So these are the important terms. You have to know the meanings. The syncytiotrophoblasts grows into the endometrium, that is decidua, and as the endometrium is eroded, some of the maternal blood cells are opened up and blood from them fills the lacunar space. So the lacunae have maternal blood. So whatever blood lacunar spaces has, it is maternal blood, which is after the erosion of endometrium. So each trabecule is initially made up entirely of syncytiotrophoblasts, and later cells of cytotrophoblasts begin to multiply and grow into each trabecule because there is erosion and they are getting into the decidua, and this is called as primary villi. Again, here also primary villi, an extra embryonic mesoderm that invades the center of each primary villus, and this extra embryonic mesoderm becomes secondary villi, and soon after fetal blood vessels can be seen in the mesoderm forming the core of each villus, and that villus is called tertiary villus. So always remember, tertiary villus has vascularity. Blood vessels are seen in tertiary villus. Thus, the maternal blood in the lacuna is never in direct contact with the fetal blood. They are separated by, so there is a barrier between maternal blood and fetal blood, and that is placental barrier. Syncytiotrophoblasts, cytotrophoblast, basement membrane, mesoderm, endothelium of the fetal capillaries, and together they are called as placental barrier or placental membrane. So this can be a question which can be formed into all of the above, none of the above, or any of the above, except. So that kind of questions, whenever you see more than 4 things in a topic, so that those type of the questions that can come up. Next, placenta at term. So once the pregnancy comes to term, how does the placenta look? So it is a circular disc, discoid shaped circular disc with a diameter of 15 to 20 centimeter, thickness of 3 centimeters at its center, and weight of placenta is 500 gram. Proportion of weight of placenta to the baby or the fetus is 1:6 at term. That means 1 part of placenta and 6 parts of baby. That means 6 into 5, almost 3 kgs the fetus is weighing, and the placenta is 1. Okay, so the 500. So that is what it means. So 1:6 is the ratio at term. But there is a time period where the placenta and the baby or the fetus weighs equal. And that time period is 17 weeks. It is a frequently asked question again. So when does the placenta and the fetus weigh the same? It is 17th week. After that, the proportion starts to differentiate. And 30% of uterine wall placenta occupies. Presence with 2 surfaces, fetal and maternal surfaces with a peripheral margin. Fetal surface is covered by smooth and glistening amnion with the umbilical cord attached at or near its center. So almost always it is center attachment is umbilical cord. And at term, about 4/5 of the placenta is of fetal origin. That means 4 parts of 5 is fetal origin. 1 part is from the maternal origin by term. By the time the term has come. So maternal surface rough and spongy, dull red color, and this is due to the maternal blood circulation. It appears dull red color, and 10 to 38 convex polygonal areas are known as lobes, which are limited by fissures. So these lobes are seen on the maternal surface. And each fissure is occupied by the decidual septum, which is derived from the basal plate. The total number of placental lobes remains the same throughout the gestation, and individual lobes continue to grow. So there is something called lobe and lobule. So lobule is cotyledon. So lobe is different, cotyledon is different. You're not supposed to get confused. So cotyledon or lobule is a functional unit of placenta, because functional unit of placenta can be, which the options is given as lobe, lobule, and cotyledon might not be mentioned at all, lobe, lobule, and others. So it is frequently the answer would be lobe. So no, the answer is lobule or cotyledon, originating from the primary villus stem. The maternal portion of the placenta amounts to less than 1/5 of the total placenta. Only the decidua basalis and the blood in the intervillus space are of maternal origin. So the blood circulation and the decidua basalis, these are only parts which are from maternal origin. Like separation of placenta. When does placenta separate? It is always after the birth. If it is previously separating, then it is a pathological condition. the mother and the fetus. So the pregnant lady needs assistance during that time. So otherwise, the placenta usually separates only after the birth of the fetus. The line of separation is through the decidua spongiosum. And Aiapget's membrane. This is one thing which is frequently recently asked. So fibrinoid deposition of the uterus, uterine syncytial trophoblast. So limits the further invasion of the residua by the trophoblast. So absence of this membrane causes placenta accreta. Placenta accreta, if it is in one of the causes, is because Aiapget's membrane is not there, and it is a fibrinoid deposition. Next is fetal fibronectin. It is also known as trophoblast glue. Why? Because it plays a role in the migration and attachment of trophoblast to maternal decidua. So it is responsible for the attachment of trophoblast to the endometrial cavity or endometrial lining, maternal decidua. The presence of the fetal fibronectin, FFN, in cervical or vaginal fluid can be used as a prognostic indicator in preterm labor. Hofbauer cells, these are fetal macrophages in stroma of placenta. These are few terms which can be asked as questions. Next, placental circulation. It is divided into uteroplacental circulation and fetoplacental circulation. Uteroplacental circulation, it is circulation of maternal blood through the intervillous space, and a mature placenta blood volume, this is a question that can be asked, is 500 ml. Mature placenta blood volume, how much it produces? 500 ml, and among that 300 ml is in villi system and 150 ml is in the intervillous space. And in villi system, which is the major contributor, it is tertiary villi. And uteroplacental blood flow at term, it is 450 to 650 ml per minute. So these are the few measurements which you should remember, which are important. So volume of blood in mature placenta is 500 ml, and in intervillous space it is 150 ml, and also 350 is in villi system, villi space. Blood flow in intervillous space is 500 to 600 ml per minute. And pressure in intervillous space during uterine contraction, it is contraction, it is 30 to 50 mm of Hg. And pressure in intervillous space during uterine relaxation, it is 10 to 15 mm of Hg. Pressure in supplying uterine artery is 70 to 80 mm of Hg. And pressure in draining uterine vein, it is 8 mm of Hg. So artery pressure is more than uterine vein. Next is fetoplacental circulation. So the two umbilical arteries. Feto. So uteroplacental means between placenta and the uterus of the mother. Fetoplacental means between placenta and the fetus. What is the circulation? How is it happening? So there are two umbilical arteries. Always remember, the umbilical arteries are two and vein is one. So carry the impure blood from the fetus to the placenta, and they enter the chorionic plate underneath the amnion and branch repeatedly to form the chorionic arteries, which are end arteries, and these branches are called truncal arteries. And each truncal artery supplies one main stem villus and thus one cotyledon. So the oxygenated blood then returns to fetus via single umbilical vein. So always remember artery, umbilical artery. So usually what happens? Usually is artery actually carries oxygenated blood and vein carries deoxygenated blood. But in fetus, it is not the same. So umbilical artery carries deoxygenated blood and umbilical vein carries oxygenated blood. And umbilical artery gets the blood from fetus to placenta, and umbilical vein takes from placenta the oxygenated blood, which is recirculated and made oxygenated in the placenta. It takes from the fetus, from the placenta to fetus, the umbilical vein. Next, these are few measurements which you should remember. And fetal blood flow through the placenta, it is 400 ml per minute. Pressure in the umbilical artery is 60 mm of Hg. Pressure in umbilical vein is 10 mm of Hg. So you should remember the difference between uterine artery and umbilical artery. Don't get confused. And fetal capillary pressure in villi is 20 to 40 mm of Hg. Oxygen saturation in umbilical artery is 50 to 60%, and oxygen saturation in umbilical vein is 70 to 80%. And partial pressure of oxygen in umbilical artery is 20 to 25 mm of Hg, and oxygen in umbilical vein is 30 to 40 mm of Hg. So easily these can become questions, because whoever sets the questions, wants you not to answer the question. That is their what to say, their motto. So but you should remember and recall and answer these type of questions. Next, functions of placenta: transfer of nutrients, and that is in the form of respiratory, excretory, nutritive, and endocrine function, barrier function, immunological function. So this is just put the in broadly what are the functions. So the aspirants can go further and read about it in detail. Next, mechanism involved in transfer of substance across the placenta. So what are the physiological mechanisms through which the transfer is happening? They are simple diffusion and facilitated diffusion, active transfer, endocytosis, exocytosis, leakage. So these are the mechanisms involved. So again, this can become any of the above except or none of the above. So those kind of questions they can form from this. Next, fetal membranes are amnion. So first one is amnion, innermost fetal membrane, and it is avascular. There is no blood supply, and it provides almost all tensile strength to the fetal fetal membranes. It lacks smooth muscle cells, nerves, lymphatics, and blood vessels. It is now being considered as a derivative of fetal ectoderm. The layer is formed between 10 to 11 days after fertilization. Next, chorion. Chorion is formed 8 days after fertilization, and chorion frondosum forms the placental villi, and chorion leaf gets merged with amnion. So next is yolk sac. So after amnion, chorion, there is yolk sac, and then allantois. What is allantois? It is a diverticulum which arises from the hindgut and grows into the connecting stalk. So amnion is a frequently asked topic from which questions can come. So amniotic fluid. Specific gravity of amniotic fluid is 1.008 to 1.010. These are all important points which can be asked as questions. Osmolality is 250 milliosmol per liter. It is completely replaced in 3 hours. It is not the same. Amniotic fluid gets it is being produced and then it is replaced in every 3 hours. And rate of amniotic fluid turnover is for 500 cc per hour. Volume of amniotic fluid is maximum between 36 to 38 weeks, which comes to around 1 liter, and then decreases such that at term, so after 38 weeks, it starts reducing amniotic fluid. It is roughly around 800 to 900 ml. So composition of amniotic fluid, water is the major contributor of amniotic fluid or major composition. So it is constituent. It is 98 to 99%. It can be asked as a question, which is what is the major constituent of amniotic fluid? It is water, 98 to 99%. Remaining solids, in that 1 to 2% include organic solids like protein, glucose, lipid, urea, uric acid, creatinine, and hormones like prolactin, insulin, and renin. And remaining are inorganic solids, and they are sodium, potassium, and chloride. Next, origin of amniotic fluid originates from maternal and fetal sources. And one frequently asked question is, which is the major contributor of amniotic fluid? So in early pregnancy, as an ultrafiltrate of maternal plasma, by the beginning of second trimester, it consists of extracellular fluid which diffuses through the fetal skin. And after 20 weeks, cornification of skin prevents this diffusion, and amniotic fluid is composed of fetal urine. So in the later months, which is a major contributor of amniotic fluid, it is fetal urine. This is a frequently asked question. And other minor contributors are pulmonary fluid filtering through the placenta. Water in the amniotic fluid is completely changed and replaced in every 3 hours. Color of amniotic fluid, early pregnancy it is colorless. Near term it is pale straw color due to presence of exfoliated lanugo hair and epidermal cells from the fetal skin. Next, function of amniotic fluid. Its main function is to protect the fetus. And during pregnancy, it acts as a shock absorber, protecting the fetus from possible extraneous injury, maintains an even temperature for the fetus. The fluid distances the amniotic sac and thereby allows for growth and free movement of the fetus and prevents adhesion between the fetal parts and the amniotic sac, and it has some nutritive value. And during labor, what is the role of amniotic fluid? The amnion and chorion are combined to form a hydrostatic wedge, which helps in dilatation of cervix. So that is one function during labor. Now, assessment of amniotic fluid. What are the tests done to assessing amniotic fluid? Because there are few pathological changes that can happen in amniotic fluid, and that will be dealt separately as a chapter in the further sessions. The pathology what are the conditions that can come up due to less amniotic fluid, more amniotic fluid. So all our abnormal colors of amniotic fluid, all that will be dealt in future sessions. So amniotic fluid index. So AFI is one thing which is used to assess amniotic fluid. So AFI, some of the largest vertical pocket of amniotic fluid in 4 quadrants of uterus. So normal AFI is 5.25 centimeter. But AFI less than 5 centimeter indicates oligohydramnios. Oligohydramnios is a condition where there is less amniotic fluid. And AFI more than 25 centimeter is polyhydramnios. Polyhydramnios means where there is amniotic fluid is more than normal content. Next indicator, assessing indicator is single deepest vertical pocket, SDVP. So one is AFI and next is SDVP of amniotic fluid. So normal range is 2 to 8 centimeter. If it is more than 8 centimeter, it is polyhydramnios. In that also, polyhydramnios is divided into mild, moderate and severe. And in that, mild is 8 to 11, 12 to 15 is moderate, and more than 16 is severe. So less than 2 centimeter is oligohydramnios. Umbilical cord. Umbilical cord of Eunice extends from the fetal umbilicus to the fetal surface of placenta or chorionic plate. Now it develops from the connecting stalk. And in early fetal life, cord has 2 arteries and 2 veins. So it has 2 arteries and 2 veins. But later, right umbilical vein disappears and leaving only the original left vein remaining. So thus a term umbilical cord has 2 arteries and 1 vein. So always remember there are 2 umbilical arteries and 1 umbilical vein. So structure and function, the length is 55 centimeter and range is between 30 to 100 centimeter. If it is less than 32, then it is abnormally short umbilical cord. Even abnormalities of umbilical cord will be dealt in future sessions. Folding and tortuosity of vessels within the cord itself creates false knots. So which are essentially varices, and the 2 arteries are smaller in diameter than the veins. When fixed in their normally distended state, the umbilical arteries exhibit transverse intimal folds of Hobokenk across their lumen. The extracellular matrix, which is specialized connective tissue, consists of Wharton's jelly. So Wharton's jelly is a specialized connective tissue which is present in umbilical cord in the extracellular matrix. And anatomically, umbilical cord can be regarded as a fetal membrane. It can be regarded as a fetal membrane. The oxygen supply to fetus is at the rate of 5 ml per kg per minute, and this is achieved with cord blood flow, which is about 105 to 320 ml per minute. Normally, the umbilical cord is inserted at the center of fetal surface of placenta. So, if the umbilical cord is inserted anywhere else, it becomes a pathological condition. So that will be again dealt. Whatever pathologies are there related to all these topics will be dealt in the future sessions. The fetus. Now coming to fetus. So 3 periods are distinguished in the prenatal development of fetus: ovular period or germinal period, which lasts for first 2 weeks following ovulation. In spite of the fact that ovum is fertilized, it is still designated as ovum. Embryonic period begins at the 3rd week following ovulation and extends up to 10 weeks of gestation, that is 8 weeks after conception. The crown rump length of embryo is 4 mm. And fetal period begins after 8th week following conception and ends in delivery. So a fetus has 3 periods: ovular period or germinal period, and embryonic period and fetal period. So the chronology in the fetal period is henceforth expressed in terms of menstrual age and not in embryonic age, because the age of fetus is mentioned as weeks, of how many weeks the mother has skipped the menses. It is based on that. Length, age and growth of fetus. So length of fetus, to determine the length of fetus, the measurement is commonly taken from the vertex to the coccyx, that is crown rump length, not till the legs. It is wrong. So vertex to the coccyx is crown rump length in earlier weeks, and while from the end of 20th week onwards, the measurement is taken from vertex to heel, that is vertex to heel after 20th week, that is crown heel length. Calculation of the length is crown heel length measurement of the first 5 months is calculated by squaring the number of lunar months to which the pregnancy belongs. So first 5 months, if the pregnancy is lunar, for example, 3 months. So 3 into 6 will 3 into 2 will become 3. Sorry, squaring the 3 into 3 will become the crown heel length. And in the second half, the same is calculated by multiplying the lunar months by 5. So after second half, that means after 5 months, after when the second trimester is about has begun, it becomes 5 into how many ever months is there. So 6 months, 6 into 5 becomes the crown heel length. So the length is always expressed in centimeters. Age of the fetus. Gestational age is the duration of pregnancy calculated from the first day of last menstrual period, LMP. It is greater than post-conception fertilization age by 2 weeks. The length is more reliable criterion than the weight to calculate the age of the fetus. In first trimester, crown rump length plus in mm plus 6.5 becomes the gestational age in weeks. Next, growth of the fetus, how it is calculated or seen. Normal fetal growth is characterized by cellular hyperplasia followed by hyperplasia and hypertrophy. And lastly, so last, it is only hypertrophy. Hyperplasia is completed. So the fetal growth increases linearly until 37th week. After that, it is controlled by genetic factor in the first half and by environmental and in the second half. The important physiological, these are the physiological factors for growth of fetus. One is race, sex, male baby weighs more than female, parental height and weight, birth order, that means weight rises from first to second pregnancy, and socioeconomic factors. Fetal growth is predominantly controlled by IGF-1, insulin, and other growth factors, and growth hormone is essential for postnatal growth. So at term, the average fetal weight in India varies from, it is a range, it is not fixed. The range is 2.5 kgs to 3.5 kgs. Principal events, this is important, of embryonic and fetal development. So 14 to 21 days of post-conception, notochord develops, ectoderm thickens to form neural plate and neural folds. 21 to 28 days of post-conception, neural folds fuse to form neural tube. 4 primitive cardiac chambers. First heartbeat is seen on day 21. So day 21 also tertiary villi is formed. After that, the first heartbeat is seen on day 21. 4 to 6 weeks of post-conception. Optic vesicles appear, complete neural tube closure, limb buds appear, and formation of face. And weeks 6 to 8 post-conception, all major structures form, complete ventricular septum is formed, and recognizably human. It becomes in 8 weeks. So that is why after 8 weeks, the fetal, in periods of fetus, embryonic, ovular, and fetal, it is called fetus as after 8 weeks. So 8 to 12 post-conception, external genitalia develop, and 20 weeks skin is covered with lanugo, vernix caseosa is present. 28 weeks testis descend to the internal inguinal ring. This can be a question. When does the testis descend? So that is intrauterine life, not after the birth. Okay, baby is viable, and 36 weeks, one testicle usually descends into the scrotum, and lanugo tends to disappear. 40 weeks, both the testicles descend into the scrotum, and nails project beyond the fingertips. Posterior fontanelle is closed. Next, fetal physiology. Nutrition. There are 3 stages of fetal nutrition following fertilization. Absorption. Absorption is from, so this is in the early stages. Deutoplasm within the cytoplasm of fetus is the absorption. In the later stages, tubal and uterine secretion helps in the nutrition in the form of absorption. Histotropic transfer means transfer from the anybody else. So that is mother for a fetus. So nidation means implantation. So implantation and before uteroplacental circulation, nutrition is provided by the mother, maternal blood. So eroded decidua, that is eroded decidua by diffusion, and stagnant maternal blood in the trophoblastic lacunae. And hematotrophic means through the blood of some other. So that is from the maternal circulation and fetal circulation. So fetal circulation becomes active and passive transfer from the fetal circulation till the 3rd week is by active and passive transfer. Okay, from the 3rd week onwards. So 2/3 of total calcium, 3/5 of total proteins, and 4/5 of total iron are drained from the mother during the last 3 months. So the maximum nutrition a mother, the fetus takes from the mother is during the last 3 months. Also, there is a high iron reserve in the fetus. Why? Because after the birth, there is low iron in the mother. by the breastfeeding, the iron demand is not met by the fetus, and that is why during pregnancy itself the iron reserve becomes more in a fetus. The excess iron reserve is to compensate for the low supply of iron in breast milk, which is the source of nutrients following birth. Next, fetal blood. Hematopoiesis is demonstrated in the embryonic phase, first in the yolk sac by 14th day. By 10th week, liver becomes the major site, and gradually red cell production extends to spleen and bone marrow. So near term, this is important, bone marrow becomes a major site of red cell production. And fetal blood picture at term is RBC is 5 to 6 million per cubic mm, HB is 16.5 to 18.5 gram per cent, and reticulocyte is 5%, erythroblast is 10%. The lifespan of fetal RBC is about 2/3 of adult RBC, that is about 80 days. So a mature adult RBC is 120 days, whereas fetal RBC's lifespan is 80 days. Cord blood level of iron, ferritin, vitamin B12 and folic acid is much higher than the maternal blood. Leukocytes and fetal difference. So leukocytes appear, WBC appear after 2 months of gestation, and white cell count rises to about 50 to 20,000 per cubic mm at term, and thymus and spleen soon develop and produce lymphocytes, and they become the major source of antibody formation. But a fetus doesn't need antibody because the fetus is in a sterile environment, and maternal immunoglobulin G, IgG, which passes through the placenta from 12th week, that is important, the time when it passes, and fetal IgG is more than maternal IgG, which is 10% higher, and IgM is predominantly in a fetus. It is of fetal origin and not maternal. And IgA is produced only after the birth. So it can be asked which immunoglobulin is produced only after birth. In response to antigens to enteric infection, it is IgA. Next, urinary system. By the end of first trimester, the nephrons become active and secrete urine. And near term, the urine production of fetus is 650 ml per day. However, kidneys are not essential for survival of fetus in utero, but are important in the regulation of composition and volume of liquor amnii. So, oligohydramnios may be associated with renal hypoplasia or obstructive uropathy. So, the importance of kidneys in a fetus is to for the function of liquor amnii or amniotic fluid. Skin, 16th week. When does lanugo appear? It is in the 16th week. And what is lanugo? It is downy, thin, colorless hair which appears. And near term, it is disappearing. Sebaceous glands appear at 20th week. And what is vernix caseosa? It is the secretion of the sebaceous gland mixed with the exfoliated epidermal cells is abundantly present, smearing the skin. The horny layer of epidermis is absent before 20th week. It appears only after 20th week. And gastrointestinal tract, 10 to 12 weeks, fetus starts swallowing amniotic fluid. And meconium is one important thing in obstetrics. It can be a question. Meconium appears at what time? Between 20th week and at term. So it is distributed uniformly from gut up to the rectum, indicating the presence of intestinal peristalsis. In intrauterine hypoxia, due to vagal stimulation, so what happens? Meconium may be voided into the liquor amnii. So in that condition, so obstetrician will be a little careful, because there are chances that this whatever meconium is passed, the baby can the fetus can swallow, because fetus swallows amniotic fluid. Composition of meconium, it is waste product of hepatic secretion, and that is why it is problematic if a fetus swallows meconium. And it contains lanugo, hair and epithelial cells from the fetal skin, which are swallowed with the liquor amnii. Mucus exfoliated intestinal epithelium and intestinal juices are added to the content. And meconium, what is the color? It is greenish black color. And why it is greenish black color? It is because of the bile pigment, especially biliverdin. Biliverdin is greenish in color, more than yellowish. Next is fetal circulation. This is the last part. The umbilical vein carrying. So how does it happen? Fetal circulation. Umbilical vein is carrying oxygenated blood. So always remember, vein carries, umbilical vein carries oxygenated blood, 80% saturated blood from the placenta. So from the placenta, what happens? It enters into the fetus at the umbilicus and runs along the free margin of falciform ligament of liver. So once in the liver, it gives off branch. This is the deoxygenated blood from the through the placenta. Deoxygenated blood goes from portal vein. The greater portion of oxygenated blood mixed with some porous venous blood short circuits the liver through the ductus venosus. Remember all the highlighted words, because these are the questions that can be formed, and to enter the inferior vena cava and then to the right atrium. So ductus venosus is responsible for the blood to enter the inferior vena cava, and from inferior vena cava the blood goes into the right atrium. Now, after entering the right atrium, so the oxygen, why it is getting mixed? Because there is deoxygenated blood in the portal vein. So once the oxygenated blood goes into the liver, it gets a little mixed with the deoxygenated blood, and that is why the oxygen content of this mixed blood is less. And once it is entering the right atrium through the inferior vena cava, so right atrium, it is oxygenated blood, and this ductus venosus blood preferentially it is directed into foramen ovale. Foramen ovale is a hole which is present in between the right and left atrium. So this is only to mediate the fetal circulation during the fetal life. Once the fetus is given birth, this foramen ovale should close. That is the normal physiology by the valve of inferior vena cava and crista dividens and passes into the left atrium. So usually the blood does not pass directly from right to left, but because of foramen ovale, the blood passes from right to left atrium. And here it is mixed with small amount of venous blood returning from lungs through the pulmonary veins, and pulmonary veins only small amount because there is no active respiration by the lungs. So that is why the pulmonary circulation is not that active in fetus. You should remember that. This left atrial blood is passed on through the mitral opening into the left ventricle. So once it has reached left atrium from right atrium, it goes into left ventricle. So remaining lesser amount of blood after reaching the right atrium via superior and inferior vena cava passes through the tricuspid opening into the right ventricle. Obviously, it also goes remaining whatever. So because the hole is there between left and right atrium, maximum goes into the left atrium. So from right, a few small amount of blood goes into the right ventricle. So during ventricular systole, the left ventricular blood is pumped into the ascending and arch of aorta and distributed by their branches to heart, head, neck, brain, and arms. So the blood flow is to the these parts, heart, head, neck, brain, arms, is from left ventricular blood. The right ventricular blood with low oxygen content is discharged into the pulmonary trunk. And since the resistance of pulmonary arteries during fetal life is very high because there is no active respiration, the main portion of blood passes directly through the ductus arteriosus. So three things you have to remember. What are the meanings? Ductus venosus, ductus arteriosus, and ductus arteriosus, ductus venosus, and foramen ovale. So these are the three things you have to remember in fetal circulation. So ductus arteriosus into the descending aorta, bypassing the lungs, where it mixes with the blood from the proximal aorta. So 70% of cardiac output is by the ductus arteriosus to the descending aorta, and 40% of combined output goes to the placenta through the umbilical arteries. So placenta, what comes from placenta is oxygenated blood to the fetus. That is 80%. Now this 40%, whatever goes to the placenta through umbilical arteries, deoxygenated blood. So this deoxygenated blood leaves the body by way of two umbilical arteries to reach the placenta, where it gets oxygenated and gets ready for recirculation. The mean cardiac output is comparatively high in fetus. Why? Because the blood circulation is more in fetus than placenta, and is estimated to be 350 ml per kg per minute. So what are the changes that occurs after birth? The hemodynamics of fetal circulation undergoes profound changes soon after birth. Due to what? Due to cessation of placental blood flow. So immediately after the birth, placenta separates and umbilical cord is cut. So placental blood flow is not there. Now, immediately after birth, the respiration is initiated. So pulmonary circulation begins. So there are few changes in the fetal circulation. What are they? The following changes occur in the vascular system: closure of umbilical arteries. Yes, closure of umbilical vein, closure of ductus arteriosus, closure of foramen ovale. These are the normal physiological events that happens immediately after the birth of the fetus. So closure of umbilical arteries, functionally it closes instantaneously, preventing even slight amount of fetal blood to drain out. And actual obliteration. Obliteration means actual closing. Anatomical closing happens in 2 to 3 months. The distal parts form the lateral umbilical ligaments and the proximal parts. So whatever close, this becomes a few parts in the fetus. So what are after the birth? So they are, first one is lateral umbilical ligaments and then superior vesical arteries. Closure of umbilical vein. what they do. The obliteration occurs a little later than the arteries, allowing few extra volume of blood to be received by the fetus from the placenta. After obliteration, the umbilical vein forms a ligamentum teres. So always remember ligamentum teres, which is the source. It is umbilical vein. And ductus venosus, what it becomes? It becomes ligamentum venosum. Closure of ductus arteriosus. Within few hours of respiration, the muscle wall of ductus arteriosus contracts. Probably why it contracts. The reason could be because there is rising oxygen tension of the blood flow through the duct, and that is why there is oxygen tension, because there is high level of prostaglandins. So functional closure of ductus arteriosus, when it occurs soon after pulmonary circulation starts. And pulmonary circulation starts when? Immediately after the birth, when the act of respiration starts. So the anatomical obliteration, anatomically when it closes, it is 1 to 3 months and becomes what it becomes? Ligamentum arteriosum. And closure of foramen ovale, increased pressure of the left atrium combined with the decreased pressure on the right atrium. So because pulmonary circulation is happening, so it is divided, the circulation is divided and there is not much burden into the right atrium. So that is why the functional, the anatomical closure happens in foramen ovale. So functional closure happens soon after the birth, and anatomical closure happens immediately, 1 year after the birth. So you have to remember all the years and time when it closes. So functional and anatomical. Within 1 or 2 hours following the birth, the cardiac output is estimated to be 500 ml per minute. And heart rate, what is the heart rate immediately after birth? It is 120 to 140 per minute. So this completes the 3 topics. Thank you.